On behalf of Boulder Community Health, I'd like to introduce our speaker, Jie Mao. Dr. Mao received her medical degree from the University of Florida. She then went to the University of Colorado Health Sciences Center, where she completed a one-year internship in general surgery, 4 years of residence in radiology, and then a one-year fellowship in vascular and interventional radiology. In 2003, Dr. Mao joined the medical staff at BCH, where she practices both interventional and diagnostic radiology. She has performed more than 2,000 interventional radiology procedures for treating varicose veins. Welcome, Dr. Mao.
Hi, good evening. Thank you for joining us tonight. I hope the upcoming lecture is informative and helpful. I have given this lecture quite a few times before, so thank you for those who are listening to it again. And you might see some slides that are familiar. I joked earlier with Karen that I stopped taking pre and post pictures about 500 or maybe even less than that procedures in, because we decided we just didn't want to keep track of all those pictures. So apologize if the pictures are repeat, but the results are the same, if not better, arguably better today. So let's begin. Okay, I'm going to start by showing some vein pictures. I believe many of you would resonate with these pictures. And there are some pictures that could be disturbing for patients because they are a little bit revealing of some of the ugliness of what varicose veins can cause in a medical sense. So please pardon those, but they are true and real, and everyone should be educated about them. And after I show these pictures, we will go into talking about treatment options for varicose veins, and also historically what was done, what are currently done today. We will show some pre and post pictures, and also, of course, some videos on how the procedure works. So here are some patient legs with various sizes and locations of varicose veins. I believe most people in the community, when they hear varicose veins, they're thinking about the tortuous, protuberant veins, thumb-sized veins that are on people's lower extremities. These would be very good and classic examples of what is officially termed varicose veins. These are not as protuberant, they're not as ropey, they're not thumb size. They are clustery, usually blue and purple in discoloration, and they can also be anywhere in the legs. These are called telangiectasias. They're not officially called varicose veins. They are a step ahead of varicose veins, one might say, but oftentimes they happen at the same time as varicose veins. So it is a milder form of venous insufficiency, which we will explain later, compared to varicose veins. These are typically cosmetic, typically don't cause symptoms, but they can, and of course they are unsightly. So I often have patients to come in and want to get a varicose vein evaluation, but at the same time they also want to get these treated at the same time. And then going even further, milder degree of venous abnormalities, if you want to call it that, are these slightly, they're smaller, they're less clustery, and they are less dark in discoloration. These are still some of the more prominent ones, but they are called spider veins. And I'm sure a lot of you have also heard that terminology. I'm showing these pictures because they will show up on your screen, but many times we have spider veins that are much lighter and much smaller than these. They are also still spider veins. Treatment of these will be purely for cosmetic reasons. Insurances won't cover these because if this is all that you have, there's a very good chance you will not get those ropey varicose veins that we had seen earlier. But of course, we can always evaluate and double check and confirm that. So people who have confirmed spider vein only will be just treating them for cosmetic reasons. Okay, so these are the veins that we have just covered. They're ropey, bulging varicose veins. There are telangiectasias, and then there are spider veins. Many times they are just visible and have no symptoms. Most of the time, the patients that present to me that come to Boulder Community Health are patients who do have symptoms, especially those associated with the varicose veins. And we will talk about what those symptoms are in just a little bit. Okay, so now we're gonna just dive straight into varicose veins, which are the ropey varicose veins. I will talk about treatment of the telangiectasias and the spider veins after we talk about varicose veins. So these slides are specific to varicose veins. They're very common. I'm sure we've all walked down the street and saw people's legs and see them protuberant veins. They definitely increase with age because our tissues become more elastic. Gravity takes its toll, and they also are more prominent with heavier body set or obesity. And if you can think of it as we have arterial system that supplies blood down to our feet. Then they got to come back up to the heart via the venous system. So here, varicose veins are the venous system. We're not talking about poor blood flow to the legs, which would be arterial. We're talking about poor blood return from the legs to the heart, which is venous. And the venous system has to fight gravity to do that to begin with. And if you imagine if we had additional weight on that, which would be, it could be pregnancy, it could be obesity, that could actually add an additional weight that your veins have to fight against in order to return the blood back to the heart. And as we will see, that becomes eventually potentially what is called venous insufficiency or valvular incompetence in the veins, which then cause the varicose veins. Okay, what are some of the clinically significant varicose vein related symptoms? Most of the time, people come in because they have heaviness, they have visible swelling, or at least a sense of just my legs get really tired and really heavy at the end of the day. I feel tired because my legs are heavy, and they feel better in the first thing in the morning, or if I drain my legs by hanging myself upside down for a while at the end of the day, they feel better. Also, if people already know about it, they wear compression stockings and they say, wow, those compression stockings really make my legs feel good. So those are some of the most common symptoms that I get. Additionally, swelling and heaviness can also cause restlessness. It can cause rash, and those rash can cause itchiness, or just in general, they can be the refluxing veins can be quite itchy, or they call pruritus in the skin, and people just keep scratching them, and sometimes they actually cause skin breaks because they're scratching them in the middle of the night and they're not even realizing it. In worst case scenarios, or some of the more severe cases, venous insufficiency that then causes swelling, that then causes rash, cause the skin to break, and the swelling doesn't allow healing very well. It's like soaking a tissue in a puddle of water, and that tissue isn't gonna stay healthy. So when you get skin break in the setting of increased pressure, that break does not heal well. It becomes ulcer, and people end up going to wound care clinic because they take a very long time to heal that ulcer. The ulcers can be recurrent even though they've treated it and it went away, but then later, if they didn't treat the underlying source and the cause, it can come back. And I am going to show some pictures of some of the lower extremity ulcers that can result from varicose veins. Here's one of them, and it is quite disturbing to see these patients. This is one of the larger ulcers of a leg that I've seen in a patient. Here's another one that has a wound care dressing covering the source of the ulcer, and additional images showing the same things. This is what we are trying to accomplish. When a patient, which is on the first image that you see on the left side of the screen, and these are images taken by this patient and sent to me, that have that little crater right outside the lateral ankle of her lower calf area. This is her left leg, and her foot is turned inward. You see that little ulcer and crater with a lot of redness around it. And if you were to palpate that skin around it is pretty hard. It's what's called induration, and inflammation is that redness that you can see, and the ulcer is that crater in the middle. So there is a vein that is causing this ulceration for this patient. We did an ultrasound and we treated that vein, and then about a couple weeks later, she sent me the middle picture, which shows that the redness is less, the crater is decreasing, but it's still there. So with continued medical management, and in that case means compression dressing, compression wrap, wound care management, eventually that ulcer completely heals, and it has stayed healed. So this is just a small example and one example of what are we trying to accomplish when it comes to varicose vein treatments. One is if patients come in with ulcers that is caused by varicose veins, oftentimes there is no vein abnormality associated with it. But we do an ultrasound, we figure it out, and then we treat it. And the point of that is to heal the patient's ulcer, which again improves health, diminishes risk of infection, and obviously less pain, less swelling, less discomfort. But also, when we catch abnormal varicose veins and bad veins earlier than they develop ulcer, then it is really preventative. And these are the medical reasons that we treat varicose veins. It's not just cosmetic. Okay, so we're gonna go over a little bit of anatomy of veins. And this is a diagram that shows, for the most part, about 90% of the time where varicose veins come from. We have our deep system, which is the darker blue in this diagram. And then we have the superficial system, which is the lighter blue in this diagram. And there is a vein that runs along the inner thigh. That's called the gray saphenous vein. That one is 90% of the source of patients' varicose veins. And then there's one in the back of your calf that's called the lesser saphenous vein. That, I'd say, contribute about the rest of 6%. And then there are 4% coming from other superficial veins in the leg. The gray saphenous vein, you might have heard, is also a vein that cardiothoracic surgeons use to bypass heart, and that vascular surgeons use to bypass an arterial system or a blocked arterial vessel. So you might have heard that those are the veins that have been harvested to treat other medical conditions. That tells you a very important thing about these veins, which is one, they're dispensable. They are harvested to do some good for us if we need them to. But when they are abnormal, And when they are enlarged to a certain size, oftentimes they're not usable. And if they're enlarged and abnormal and are causing nothing but venous insufficiency and unhealthy circulation to a person's lower extremity, that is where in the old times we used to do vein stripping to get rid of them. And today we do laser ablation or a chemical sealing glue solution to close them off. And so yes, they are absolutely sacrificable if they are the source of your problems. What happens when we get rid of these veins? Well, again, blood is coming back up from the feet to the heart through venous system. So this is just one channel that it has to go back. You block this pathway, it goes back to your heart in all the rest of the multiple other channels that are normal. So in effect, you are improving your circulation by increasing efficiency and effectiveness of your venous system to return blood to your heart. Okay, so anatomy of valvular insufficiency. What happens when we have pregnancy and added body weight and lifelong worth of gravity toll on our venous system? When we're born, they're supposed to help us keep the blood up. But then eventually with all these problems, they end up failing and cause blood to go back down with all of these causes. How does that happen? When we have normal venous system, all of our veins have what's called valves in them. And there are different valve points all along our lower extremities and upper extremities. Anywhere that we have a vein, we have valves. Because again, these valves, they are supposed to be normally shaped like a teepee. So like a normal pointy shaped teepee leaflets. So when you squeeze your leg, blood is, the leaflets are supposed to open, blood is supposed to go up, and then when you relax, leaflets close, blood cannot come down because the leaflets are preventing the blood from coming down. When the valves are flopping in the breeze and they don't close because of insufficiency, because one, again, gravity's pulling on them. There's too much weight up on top for blood to go back. They flip and they become incompetent. And when they're incompetent, when you squeeze your legs, blood goes up, you relax, they come right back down with gravity because the leaflets aren't touching each other to prevent them from coming down. That is the basic physiology behind venous insufficiency. And when you have all that blood that is pulling down, instead of going back up, that vein that is supposed to be that big gets bigger and bigger and bigger and bigger, and eventually has to go somewhere. So it goes out into the little skin veins that normally drain inside. Now they're getting backed up because the central system's getting backed up, and eventually those leg veins on the skin become those ropey varicose veins that you see. So let's look at a video that tells us how this looks like. So on the left side of the screen, you have normal vein with the valve leaflets touching. And as we walk and squeeze, well, that was short. The leaflets actually go back and touch each other and prevent the blood from coming down. On the right side of the screen, it's incompetent and blood is just going right back down. And you see that vein is enlarged. Okay, so when you have varicose veins, many people have come to me and say, well, I saw the lecture and I heard the conversation and I want to get these checked out, but boy, I am wondering if this actually is the source of my heaviness, source of all these other issues that I'm dealing with, but I've been told that they're just really common and I just need to live with them. And yes, I am hoping with continued education and ongoing conversation about this, that people recognize that yes, they can't just be cosmetic. but they can also cause lots of medical issues. And insurance companies are actually getting better at approving these for those medical necessities, for those that satisfy medical necessity. What else can you do to help yourself? I think staying active is good for all of us. Maintaining healthy body weight in general is good for all of us for many, many reasons, whether it's diabetes or heart disease, and in this case, helping your veins to do their jobs. So the exercise part, there is a balance to that. I know competitive fencing athletes who are on their feet all day long because that's the sport, and they get very large varicose veins. Skiers, large varicose veins, competitive skiers. Runners, same thing. So you see a lot of these athletes wear compression sleeves or compression socks while they're exercising to help them. There is actually a science behind that. Not only do they feel better, they're helping their veins at the same time while they're exercising so vigorously. For those of us that are not competitive athletes, wearing those compression stockings do the same thing. They help support your tissue as we get older. They make you feel better, and they slow down, if sometimes not completely prevent, varicose vein development. So I am a big fan and a big proponent of good fit, well-fitted medical compression socks. Actually, I wear them pretty much every day for myself because I'm on my feet a lot. And then when you can, if you're in the theater, put your feet up. If you're watching a show for a couple of hours, or if you're resting, go ahead and put your feet up. If you're on a long plane flight, I think those stockings are really helpful. And then, of course, coupled with getting up and walking around. I'm sure we have all heard these things multiple times, but these are the reasons and some of the real medical reasons why people recommend that. Okay. Compression, I in general would recommend 20 to 30 millimeter mercury grade compression. For those ulcer patients that you've seen the pictures of, there's many times that they start with that or even lower because they can't tolerate the compression grade because it's so hurtful. But once the ulcers heal, they sometimes have to go higher to even custom made. For example, 60 to 70 millimeter mercury, 70 to 80 millimeter mercury. But in a medical supply store, or if you're going to buy yourself a pair on Amazon or something like that, 20 to 30 is what I would recommend. Lowest I would go is 18 to 20, but really anything less than 18 millimeter mercury is probably not doing a whole lot of good. Okay, some of the herbal supplements that have like what I'm spacing on the name, horse chestnut. Sometimes people have said, okay, that really helps me, but just like any other medical supplements or natural supplements, it is variable from one person to another, and there really is no scientific data to back any of it up. So you would have to try it, see if it helps you, continue it if it helps you. It doesn't harm you or hurt you, but I don't think anyone can promise a result, universally across. Okay, so let's talk about some of the treatments now. For the wound care patients, they go to our local wound care facility. We have a wonderful wound care clinic. There are surgeons and infectious disease doctors that staff that, and the wound care staff are fantastic at helping patients with wound care management. They also will fit and supply them and get them the compression stockings needed. For treatment of varicose veins, we start with an ultrasound. It is very important that that ultrasound is done with knowledgeable staff so that the correct location, number, refluxing time, size of the abnormal veins are identified. And also all of them are identified, not just one or two. Because if you just treat one or two and you leave a couple others, chances are the veins will come back, and it might even be harder at that time to treat the leftover one or two. There are vein stripping and ligation. That are the old-time surgical treatments, larger scars and much more invasive, much more black and blue. There are the traditional phlebectomies, which is the traditional pulling of the veins. So today, we don't typically do traditional phlebectomy or ligation or stripping anymore. We do either radiofrequency ablation or laser ablation to close off the veins. And I will show a video of that and how that works. Those are heat-related treatments. Or there are non-heat-related treatments, and that is Varithena or Venous Seal, are those the two most common names of the products that are out there. They are, I guess for lack of a better way to describe it, they are a type of a sclerosant that essentially has a gluing effect on the venous system. And different companies are approved and recommended for different size of veins. Okay, so let's start with the ultrasound. Here is an example of an ultrasound that shows venous insufficiency, and this is what we're looking for while we're doing that ultrasound. So how it works is, if you were to make an appointment, it will be with the ultrasound department. The sonographers will get you back to the room, get you changed, start the ultrasound, and get some basic information like vein size and also whether they recognize any insufficiency or not. And then I come in and I supplement the sonographer's study with my own. And what I am looking for at that time would be what this video is showing, which is you squeeze the leg, the blood is flowing in one direction, you let go, it flows in the other direction. One direction is shown by one color, in this case the orange. The other direction is shown by another color, in this case the blue. So depending on the direction of blood flow, we are counting how many seconds that reverse direction is happening while you are in an upright position. Because again, we spend 50% of our time, sometimes even more, in an upright position. So gravity takes its toll. By counting that second, it tells me how severe your venous insufficiency is, and how does it explain or not explain what I see on your legs and what you're telling me that you're feeling. So we put all the pictures together and then make a recommendation of, yes, you have medically significant venous insufficiency that should be treated, and these are the treatment options. Or, no, I think you're totally fine. Your legs are looking pretty healthy. And what are the chances of you developing varicosities in your lifetime? So it is an assessment, and it is either, yep, let's get it done because you need it, or it's a reassurance, don't worry about it, you'll be fine, and here are some other recommendations that I would have. And just so you know, under normal circumstances, the number of seconds that you're supposed to reverse the blood as somebody squeezes your leg, blood's going up, they let go, blood comes down. If your valves are competent, that blip of a comeback, it should be less than half a second, okay? Because your valves are closing as soon as you let go, and then less than half a second later, your blood is going back up in the correct direction. In someone with very abnormal varicosities and venous insufficiency, usually we're looking at 5+ seconds, and sometimes it never stops. It is constantly refluxing greater than 10 seconds, and it never goes back to the normal direction. Those are typically the patients that have the most amount of symptoms. So we look at that while you're in the ultrasound department. Once we identify what are the treatment options you have, We go through insurance authorization. Insurance then gives us a yes or no on whether they think what you have is medically necessary and medically indicated for them to approve or not approve your procedure. And once approved, the interventional radiology department will call you to schedule. And once you come in that day, it is an outpatient procedure, typically with no sedation, and that's variable based on the procedure and also the patient. And everything is done in a sterile fashion. Your leg is prepped, it's draped. My staff and myself are gowned and masked, and it's a sterile environment to do this procedure. It is typically an outpatient procedure. So you come in, bring your stockings with, which will be a prescription that's given to you at the end of the ultrasound department visit. And you come in, we do the procedure, you put your stockings on, you go home. If you're not needing sedation, you can drive yourself in, drive yourself home. And if you need sedation, then there is a recovery time associated with the sedation, and then you'll need a ride home from that. So let's show you a picture of the laser procedure. This is where we see the varicose veins. We deliver what's called tumescent anesthesia around the vein, so that the tissue around the vein isn't lasered during the laser procedure. You then get into the varicose vein, as this diagram is showing. You use ultrasound guidance, you thread the laser catheter inside the vein, then you turn on the laser and you burn the vein from the inside while you are pulling back the catheter. At the end, that vein is essentially heat closed. You apply compression stockings surrounding that closed vein, which again supports the tissue, and it facilitates the vein staying closed so that when you heal your lasered vein, they heal shut rather than gaping open. And it is something that we emphasize very much during your ultrasound department as well as your procedure time, because I can do the procedure all day long, but if you don't wear the compressions afterwards, much higher chance of procedural failure than otherwise. Okay, this is an example of ultrasound-guided sclerotherapy. That is typically done same time, if not at least on the subsequent follow-up visit after your laser ablation. What happens is you can laser the great saphenous vein, which is the straight inner thigh vein. You can laser the lesser saphenous vein in the back of the calf, but you can't laser all the other serpiginous ropey veins that are associated with those main truncal insufficiencies. Those other veins and multiple other connection channels in the leg are treated by sclerotherapy, which is an injection of a sclerosant by ultrasound guidance. And that is what this looks like, is you get the vein, you put the needle in the vein by ultrasound guidance, and you inject the sclerosant, which is that bright line that, and I'll show that again, which is that bright line that you see showing up inside the vein. There's the needle, and there's that bright line of sclerosant that's being injected. Okay. We've already seen some of these pictures of the pre-varicose vein appearance. And with veins this size, there's a third treatment that's called microflebectomy. And what that is in addition to sclerotherapy and in addition to laser treatment, we sometimes have to actually physically remove these ropey varicose veins because they won't go away because they're simply too big. You can't inject enough sclerosants in here to make them go away, or there are too many smaller channels inside that will simply feed back into the cavity of these big ropey varicose veins regardless of the other two procedures that you do. And to get 100% resolution of the appearance of these veins, you got to actually physically remove them. So what we do on the day of your procedure in that case is we'll have you on your upright position, and I will use a marker and mark out these veins. Okay, so these are some of the examples of veins that we mark out. Again, these are old pictures. We don't do nearly as much marking and microphlebectomy today, but then your leg is prepped, you're on the table, and we use those markings to disrupt the veins by removing small segments of them, and the incisions are very, very small. They're no longer the big ligation incisions that surgeons used to do, or the standard phlebectomies that they used to do. These are called microphlebectomies. So sometimes patients need all three procedures in order for the entire varicose vein system to be treated. Okay, so some of the pre and post pictures. Pre's on the left, post is on the right. Our goal, again, is to not only get rid of unsightly varicose veins, but symptoms. We want the leg to feel better, we want the circulation to be healthier, and we want to prevent future problems from developing down the road. A lot of the prevention is going to be application of compression even after healing, because nothing really that I do today is going to prevent you from developing venous insufficiency in another vein that right now is normal. And we're certainly not going to get rid of normal veins. So sometimes, depending on activity level, genetic predisposition, people come back with recurrent episodes. That is not uncommon. Okay. So that's the pre of that patient that we drew on the table. That's her post. Same thing with that patient with the ropey veins, and that is his post. This particular patient was actually a competitive skier, the one on the right side of the screen, who could not tolerate skiing much longer because of the size of these varicose veins, and subsequently returned to skiing after treatment. Here is another example of ulcer patients that, again, we want to close up the ulcer by treating the underlying venous hypertension and venous insufficiency. Okay, this is that patient that had really bad looking legs on the day of procedure, or at least on initial evaluation in September, and by December, everything healed up. And this is a patient that had this venous stasis ulceration for 10 plus years. Nobody identified venous insufficiency as a source until eventually he made his way to me, and it was literally closing skin in front of your eyes as we speak. Okay, last but not least, let's touch up on the other venous pathologies that we talked about, telangiectasias and spider veins. What are these treated with? Well, they're not candidates by laser. They are candidates only for sclerotherapy. So let's take a look. Here are some of the telangiectasias. These are the spider veins. And here is injection of these veins with sclerotherapy. So the syringe, so this is me, and these are real patients here. The syringe is filled with sclerosant, and it's a very, very tiny needle that you try to get into these tiny little veins. So if you can see, getting into the vein, and then if you look at this area where the veins were, by injecting, they blanch out. Here's another example. So look at the streaky red veins on this leg, and then look at with injection, they are blanching out. The sclerosant is following these veins. So what to expect after a sclerotherapy treatment? This is pre on the left-hand side of the screen and post on the right-hand side of the screen. When the injectant first goes in, it is really rewarding because you see all those veins all go away within about less than a minute. unfortunately, they all come back looking red and angry as ever on the right-hand side of the screen, because that's what the sclerosing does, is it causes an inflammatory reaction following the course of all those injected veins. And in about 5 weeks or so, 3 to 5 weeks, that inflammatory reaction goes away and the veins go away with them. So it's not an immediate gratification, except for the first 2 seconds of it. And it is something that, you might want to do if you're going to go to a beach or, show your legs, maybe not a good time to do that right before. Okay, another example of tiny little veins that I end up spending some time injecting, and red following the streaky veins, and then it'll go away. Okay? There are other venous abnormalities that are associated with varicose veins. We will find them if we have a suspicion of it at the time of your leg ultrasound. And I won't go into details on all of those, but pelvic congestion, May-Thurner syndrome, and nutcracker syndrome are etiologies that are above the inguinal ligament, or vein pathologies that are above the hips that are not seen by ultrasound, that we sometimes suspect based on what we're finding from your ultrasound of your legs. And if that's the case, we will be having a discussion about what else can we do imaging-wise to find that, to identify that, and if it's truly identified, they have to be treated. Otherwise, the varicose veins in the legs will come back. But those are a much deeper conversation and a much more extensive conversation to have for this lecture. And I think that is the end of my slides. And I am hoping that what we've talked about today have been helpful and educational and informative, and helping you make some educated decisions based on where you should go from here if you have any of those venous conditions. And thank you again for your attention and listening. Thank you.
Thank you so much, Dr. Mao. That was very informational. And we want to remind our audience that now is the time for questions. We have received some questions, but if you have more questions, please put them in the chat box, and we'll get to as many as we can. So in no particular order, wanted to find out can you get a tattoo on the spider veins?
A tattoo on the spider veins by a tattoo artist to cover it up? I assume yes.
And that won't mess with the spider veins in a negative way?
Well, it'll obliterate them, because tattoo is inking and getting into your superficial skin layer, right? I mean, those veins are right there, so it'll just cover them up. Could they blossom some other place? So for example, when somebody comes in and they say, I got these cluster of spider veins, so we treat them. Well, your body has a tendency to, for whatever reason, develop some of those veins. So if you cover that one spot up, could you just blossom spider veins some other place? I assume. But there's no medical risk to getting tattoos on spider veins.
Okay.
Now, I'm talking spider veins though. I want to clarify, it's not the telangiectasias, because if you had a cluster of veins as dark as those telangiectasias, I think the tattoo artist would get into quite a bit of bleeding.
Okay. Thank you for that clarification. So they may want to see you first.
You should probably treat the telangiectasias if it's really that big and that clustered. You should probably treat those first before tattooing.
Okay. And make sure that it is a spider vein before you tattoo as well.
Well, yeah, if it looks like the spider veins, it's yes. Yeah. But if it looks like the big black cluster, then it's telangiectasias.
Okay.
Yeah.
Okay. This person had a blood clot in the greater saphenous vein.
Yep.
After the clot was resolved, they started seeing the swollen veins and feeling pain.
Yes.
Do you know if the clot caused the veins or did the veins cause the clot?
I think the veins caused the clot because why did you clot the great saphenous to begin with? You clotted the great saphenous because your valves are probably broken in the great saphenous, which means there's blood pooling to begin with, and stagnation of blood causes blood clots. Unless, you had an ankle surgery or a knee surgery or a hip surgery that actually, because of immobility, could explain the clotting. But if there's nothing else to explain the clotting and it just happened randomly, I am going to suspect the great saphenous system was abnormal to begin with, and clots make the valves break even more. So now the clots have cleared, there's a good chance the valvular abnormality is even worse. So now you're feeling the added effect of that. So if that's the case, it actually would be very important to get that looked at and actually treated and closed down.
What symptoms are necessary for Medicare to cover reimbursement for the repair of varicose veins?
It's actually, the answer to that is quite confounded. It's a whole group. It's not just one symptom. It's everything that we just talked about, which is heaviness, pain, restlessness, heaviness, swelling. There's a worksheet, there's a patient information sheet that you're going to fill out if you come to Boulder Community for this treatment that I will use based on your answer to put in my report. But the rest of it is also ulceration, dermatitis, inflammation, size of the veins, and then what we see on the ultrasound. So there's quite a bit.
Okay. What are the risks with laser ablation and non-thermal ablation, and how long is the recovery time beyond the time associated with the sedation?
So we don't do laser or non-thermal, typically are not done with sedation, unless you are just really nervous and you don't think you can stay still for the procedure. The procedure for laser is about from the time of prepping, so getting on the table, prepping, and then actually doing the procedure is about 20 to 30 minutes. So if people can stay still for that time, and we usually just chat it up. I mean, the techs, myself, and the patient, we talk about anything and everything that you want to talk about, and before you know it, it's done. So typically they're not done with sedation. The only thing that I recommend, where I usually prescribe sedation for, is the phlebectomy part, the microphlebectomy. And if it's greater than 5 or 6 stabs, then I think, yes, it's definitely reasonable to give patients sedation for that. The treatment time, so laser is about 20 minutes for me. The non-thermal, I think it's very quick. I don't do it, just so you guys know. I only do the laser. That, from what I understand, is about 5 to 10 minutes, and there is no tumescent anesthesia needed because there's no heat. So therefore, the Varithena and Venous procedures are quicker. After that, the recovery is the same. It is application of compression stockings, and for me, it's 10 days of compression up to the highest level that we ended up lasering. So if it's up the top of the great saphenous, it's pantyhose. If it's below the knee, it's knee height. It's 10 days of compression of when you're awake only. You can take it off for sleep, take it off for shower, but it's awake only. And after 10 days, most people will feel better with them on for longer than 10 days because it helps them heal faster and they're less bruised, legs not so painful when they're walking around. That's what most of my patients tell me.
Okay. And again, what are the risks of the ablation?
So deep vein thrombosis would be a risk if the glue went into the deep system, because the great saphenous system and the lesser saphenous system are direct channels to your deep system. Everything goes back to your heart via the deep system. So if the glue got into the deep system, DVT. If the laser ended up getting into the deep system, DVT. So that would be the most medically important risk that everyone should avoid, and we should try to do our best to not have that happen. I've personally not had that happen, but I can see how that could happen. There's definitely medical reports of that. Other than that, standard procedural risks, bleeding and infection.
Okay. What are the risks of blood clots messing with your veins?
Risk of blood clots messing, meaning if you had a blood clot causes a ton of inflammation and a ton of irritation. So if you had normal valves, blood clots can make those valves broken. If your blood clot is like the other patient is in the gray saphenous system and it stays clotted, meaning you never open it back up, then you pretty much just treat it yourself. Because I am shutting out your gray saphenous vein, surgeons are removing your gray saphenous vein, you just clot it off yourself. So if it stays shut, no more treatment needed. If the blood clot is in the deep system, which is what's called deep vein thrombosis, that is the biggest medical risk that we have, is those valves in the deep system. If they are damaged by whatever process, there is no treatment today for those. There's no such thing as valvular replacement. There is, but it's a really bad surgery, and there's 2 surgeons that I know in the country that offers them, and they will tell you firsthand, because I talked to them, that they would not recommend it. And we cannot obviously laser shut, or nobody can remove somebody's deep system. So the key is to prevent blood clot in the deep system.
How painful is the laser vein ablation compared to a nerve ablation?
Totally 2 different procedures. Nerve ablation of what? I would need to know. I don't know. Nerve ablation of the spine, they were talking totally different procedures. So
how about the laser vein ablation?
It's little tiny needle sticks, but for the laser, because we do need to cover up the whole vein with tumescent anesthesia, it is a skin poke to get the laser catheter in. Then it is lots of little pokes to get the tumescent anesthesia to cover along the vein. That, I think, is for the most part what patients say is the most uncomfortable part of the procedure, but it's not. Those TB shot injections that are the bump under your skin that's really painful. These are not it. These are deeper, and it's very well tolerated, but it is multiple needles, as long and as many as needed to cover up the entire length of the vein that we need to laser.
Okay.
Then after that, the laser itself doesn't hurt.
Does the sun influence the spider vein treatment?
The sun? Typically, when we do an injection, we recommend that you don't go sunbathing, because you do want the inflammation to heal, otherwise you can pigment. That's just like any scarring. If you had a cut in your arm, and if you were to not wear SPF, or go out and get tons of sun exposure, that scar or that cut can be pigmented.
Okay. Can both legs be treated at the same time?
It depends on the situation. We in a normal, healthy patient that can come in, and it's long segments of the gray saphenous vein, there's only a certain limit of the tumescent anesthesia that is medically safe to be delivered at one time. So if it's a long segment and you're otherwise healthy, we schedule you twice if both legs need to be treated. If it's a short segment, nope, we will get them both done at the same time. So it just depends on the situation.
Okay. For compression socks, can you wear them while you sleep?
You can. There's no need, because when you're sleeping, there's no gravity toll. So you don't need to. I've had patients who slept with them and really felt uncomfortable because, then it's tight 24/7. And for some patients, it can cause actually arterial issues, right? Arterial blood supply going down to the feet if it's constantly compressed. But I definitely also have patients who love them so much they wear them all the time.
Do you have a brand preference?
I personally like Sigvaris, and it's in a brochure that I'm going to hand out to you if you come see me. That's only one out of hundreds and hundreds. Jobst is, Jobst stockings is the classic hospital white stockings, but I'll tell you, stockings now they are so slick. They come in all kinds of colors, shapes, design, and all different materials. So you can get nylons for summer. You can get knit, wool for winter. They come in all sizes, all kinds. It's really, really awesome. So I don't think you have to stick with a brand. It's more important that you get accurately measured and fitted for whatever brand that you are buying.
What is the sclerosant material made of?
Sotradecol, so SDS is short SDS. Used to be saline injections. I'm sure a lot of people in the audience probably have heard saline sclera injections. Those are really painful because they're hypertonic saline. We don't use that anymore. So the sclerosant itself doesn't hurt like saline. It can burn once it gets inside the vein. Most people will tell me, yeah, that little tiny needle, you say it's tiny, but it packs a big bite. So it's actually the needle stick that is more painful than the sclerosant, but it's called SDS.
Okay. Thank you for the information on the pain too. Is telangiectasia?
Telangiectasias?
Yes. A health concern?
Typically not. I have patients who come in and say, I got this cluster of veins, and is there something else underneath? Yep, their chances are little skin branches or bigger skin branches in the subcutaneous tissue that are leading to that cluster. But I have yet to see a patient that has just telangiectasias, no spider veins, that have really bad gray saphenous or lesser saphenous system. So typically they are just unsightly.
Okay.
They can cause local symptoms like local itchiness and pain, but not medical risk.
Just a few more questions here and we'll wrap this up.
Sure.
This person has ropey veins in the back of their knees. Are there compression stockings for that situation? They're also going to be traveling on an airplane.
So thigh highs or pantyhose.
Okay. Is the sclerosant the same as a saline solution that they use for spider veins? And do the spider veins come back?
Spider veins do come back. They can come back in different areas in addition to the injected area. That's why, vein centers have these packages of, you get 5 for whatever, you get 10 for whatever, and they want you to keep coming back for treatments. But saline is what they used before, and we use SDS now. So it's not the same, but they accomplish the same thing.
Okay. This person injured their lower leg in a motorcycle accident. Now they have varicose veins in that leg. Could this treatment help remove them?
Yes. This treatment will remove varicose veins of all cause. And trauma can cause varicose veins.
Okay. All right. Well, thank you for your time tonight, but we have come to the end of our time. A recording of tonight's lecture is available at vch.org/livestream.